Start this lecture with, wait, let me look at my notes. I'm going to start this lecture with a story, and then I'm going to give you a big harangue about your responsibility as doctors, and then I'm going to show you how to use literature. Yeah. All right, so let's see. The story is, one of the residents in this room and I saw a patient together, and our plan was to add omega-3s. And so the resident asked me, the resident asked me, what's the right dose? This is for a patient with unipolar depression. And my answer was, it was kind of a rambling answer, as usual. But I was like, look, I think the last time I reviewed this literature 3 years ago, the ratio of EPA to DHA was supposed to be 3 to 1, and then you're supposed to use between 1,200 and 2,400 milligrams a day. But I haven't looked at the literature in 3 years, so we need to look it up. Yay! So we need to look it up. So we then proceeded to look it up, and then I made the resident. I did exploit the resident a little bit. I made that resident send me the review article that resident found so that I would know the right dose to use. And actually I was so lazy that I didn't even read the review article yet. I just talked to the resident on the phone and got the breakdown. So the point is, the literature changes all the time. So if an attending tells you, I'll give you an example right now. So right now, it would be standard of care and acceptable to treat a patient with bipolar 1 with a serotonergic antidepressant if that patient were on a mood stabilizer. It's not oh, you're a superstar for doing that, but you also wouldn't get sued. However, what if in 6 months there's a new meta-analysis that's actually a good meta-analysis, and it shows that those patients have increased switch rates that's it's unacceptably high, or those patients tend to commit suicide 1.5 times the rate that people who aren't on a serotonergic drug do it. So anytime you're prescribing a drug, you have to know that drug, right? This is the last part. Well, I have two more parts of my lecturing at you. So the first part is diagnosis before treatment. What does that mean? Someone tell me what that means. Diagnosis before treatment. I'll be the patient. Diagnosis before treatment. I'm a new patient. I just came to see you. Give me a diagnosis and tell me about the treatment. Someone? Seriously?
Just pick out any diagnosis? Or?
I want you to illustrate the heuristic. What does it mean to diagnose before you treat?
So establishing a clear-cut diagnosis based on criteria in DSM before starting or initiating kind of medical treatment.
Perfect. So, someone illustrate it for me.
I think it means do no harm, because if I don't know what I'm treating, what medication I'm going to give you. If I don't know, that's what my...
If I were Eminem right now, I would do a verse for you. Yeah. Okay.
Understanding the symptoms and how functional the parent or lack thereof.
Beautiful. Yeah.
Knowing how these symptoms.
Let's go back to what Tom asked, though, or said initially, which was giving a clear diagnosis. So what if you don't know what my diagnosis is? Then how do you diagnose before you treat?
Just the symptoms.
Or a provisional diagnosis based
Tom, you're rocking.
What did you say?
Provisional. So a working diagnosis, or you don't treat, right? Because you said do no harm. So if I don't know if you have bipolar 1 or unipolar depression, and I need collateral history to figure that out, am I going to start you on Prozac? No. And then the other thing about this diagnose before you treat is what happens if I'm a new resident and Tom gives me a new patient. So you're the PGY 4, and I'm the PGY 3, and you give me your patient because you're graduating, or however it works. What do I do when I meet your patient?
You should reassess kind of the diagnosis and the meds they're on.
Yeah.
Just to make sure.
Is that because Tom sucks?
No, it's just kind of to cover your own ass if they're not on the correct meds, or if you.
I would go even. I would say even more broadly that you should never trust a medical record, right? Because we don't have biomarkers in psychiatry, and therefore, what's in a medical record is another clinician's narrative about your patient. So I'm not saying like don't trust a lab value in a medical record, but when we diagnose patients, we're diagnosing them through our history taking and through our impression and through our thinking. And the way I think about a patient might be really different than the way that Tom thinks about a patient. So if Tom diagnoses someone with bipolar 2, and I think that that patient has borderline personality disorder, and I keep treating the patient as if he has bipolar 2, what am I doing? Neha.
Yeah.
Harm, 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 harm. And what am I doing if I keep that diagnosis in the chart?
Harm.
Yeah. And so what do I have to do when I get Tom's patient?
Reevaluate.
A full reevaluation. Anytime you have a new patient, a full reevaluation. And what if I only have a half an hour? What do I do then?
Next meeting, you just reevaluate
Perfect.
several sessions.
Perfect. So it's more important to diagnose than it is to treat immediately. Does that make sense? So if I work at Kaiser and I only have 2 minutes to see Tom, I'm going to have to say, hey man, I'm sorry, I only have 2 minutes because I work at Kaiser. So we're going to have to see each other 100 more times before I can write you. It's an exaggeration, but that's the point, right? Before I can figure this out. So diagnose before you treat. And if you do treat and you still don't know the answer, how do you state a working diagnosis or a provisional diagnosis? How do you put that into your note? Someone just give me an example. How would you say it in writing?
Is it a working diagnosis?
Yeah, this is a working diagnosis of depression. However, I can't rule out that there's PTSD comorbid. I just met the patient today, so on cross-sectional exam, it's really hard to figure out if there's PTSD, and I didn't even feel like I could get into that with her right now, or him right now, so I'm gonna defer that diagnosis until there's more patient report, right? I did screen for trauma, however, I still have a suspicion that there may be some co-occurring PTSD, right? So that's all you're doing is you're just describing what your thought process is as a doctor. And if that patient then commits suicide and you find out that the person had a diagnosis of PTSD but chose not to disclose it to you, did you meet the standard of care? Yeah, you did. You did all you could do, right? I mean, you asked that person, do you have PTSD? You asked in a sensitive way. You recognize that it's unlikely that a person with PTSD is going to tell you the first time that he or she meets you, and you did all you could do, and you documented your thoughts. So you're awesome. You killed it. So, I mean, it's not awesome to have an outcome like that. That was an inappropriate use of this jargon, killing it, so retract that. But, so, okay. So that was principle number 1, and then principle number 2, after diagnose before you treat, yes, is know your treatment. So this is a thought I had like all week last week, and it was unrelated to the residency program, but I was having some interpersonal conflict with another clinician, and I was just thinking like, this is not advertising. This is not a startup company. Do you know what I mean? Like, we're doctors. So another human being's life is being affected by what we do. And like another human being's suffering is potentially being protracted by what we do or made worse by what we do. And other people in that person's lives are affected. I mean, this is not like, it's not like, oh, no worries, like, go do your thing. Like, you can think of it one way and I'll think of it another way. There's a baseline competence that you have to be a doctor. And the only way to do that when you prescribe a drug is to know your treatment. Right? Because like if you don't know what the drug does and you don't know the literature around that drug, and I'm not saying you should all know every randomized controlled trial for every study, or for every drug, but you have to know the drug in a way that's more intimate and has more data and content than just someone telling you to use the drug. you have to read it for yourself. And so that's the point. You have to study it for yourself. So that's the point of this talk, which is how do you read the literature? How do you figure out if you believe what that attending who's on the inpatient unit and is treating people with bipolar 2 with SSRIs, is that okay or not? Let's look at the literature. It is probably okay. There are studies by Amsterdam showing that like it's fine, or that people seem to get better on Effexor with bipolar 2 depression. But how would you know that if you didn't look in the literature, right? So we're ready to move on to like the real talk. So what I put together is like sort of like a curated. I've been really into curation these days because there's just so much information, and I hate all that information out there. So the basic approach is get yourself a foundation, right? Like over the next 2 years, read some of the canonical books. Doesn't have to be like tomorrow, but read some of like the real stuff in psychiatry. Curated. So when you have a question, so the resident and I had a question, what's the right dose of omega-3s? Should they even be used, right? Like, I don't know, it was 3 years ago it was okay, but what about now? We look at the literature, but in a curated way. Because what happens if I type omega-3s, what?
You kept backing up
So
into
she
the
could
chair, and she would keep getting
Oh,
scared.
I'm sorry, Georgette.
So she just had enough.
So what happens if in a curated way, or if I just type omega-3s into PubMed? Everything. It's like worse than Google, right? I mean, there will be 10,000 articles that pop up. So 25,000 articles. So there's no way to do it. Okay, and then the next thing is explore. And this is like exercise, right? So like the more you get into curating the literature and like doing searches, the more you do it, the more addicted you'll get. You will start to love it. You'll be like, how did I ever do anything before this? Because you'll have your... Does anyone remember what I was talking about?
Dope journals.
Oh, so you'll have your list of dope journals. You'll type in a word and you'll get like 10 articles, and then you'll be loving it and you'll know what to do. Okay, so the explore part is just to like have fun. Like you'll find your favorite authors. You'll get into it. So this you can check out later, but it's just a list of books that I think are good. So I did like a top 10 list, and now we get to the algorithm. All right, so I'm going to do this with you because I haven't updated mine since like 2015 or 14. Okay, so everyone go to NCBI. Are you there?
No.
Just go to PubMed and go to sign into NCBI.
Do you have a sign-in for us, or are you going off?
You're going to have to create an account. If
Okay.
you don't have an account, create the account.
Okay.
So we're making an account with this.
Make an
in
account.
CBS?
Yeah. And you're going to have to verify that account too. So when everyone's done, just let me know. I'm just going to catch up on the sports from the weekend. I actually should be doing mine. But do your.
So create a PubMed account.
You're creating not a PubMed account,
Oh,
an
an
NCBI account. So you're going to sign into NCBI and creating a new account. You know you can do it with Google too, which is nice, unless the Russians hack us. Are you in? It should give you an option to do it. Does it give you one?
Yeah.
Yeah. Okay, let's go to the next step. So the next step is, does everyone have a login name on PubMed? Does it show you right here?
Oh,
Does it-
yeah.
Okay. Cool. Is there anyone who does not have a login name on PubMed? Okay. So the next thing is click on your My NCBI tab. Okay. All right, and then how are we doing on time? We're good. We're not bad. Okay, so then is everyone at the if you go to add filters,
Did you do my NCBI?
you clicked on my NCBI,
Okay.
and now you're going to go with the filters here and see this little line. Click on add filters. See where I'm pointing?
The add filters for selected database.
Yes. I should put an arrow there on mine. You got that?
Yep.
Okay. And then, is everyone on this page? Okay. So you're going to go to properties. Properties.
Select categories.
Right there. I should also put an arrow there.
Oh.
Does that look good?
It says select categories.
Properties.
Third one over. Okay. And then we're going to get a menu of items. And for now, because we want to get through all this, just pick the ones that I'm putting in, and then you can do whatever you want later. Do you see some choices? So,
Age group, clinical
so
queries.
I would pick the 5 that I'm going to recommend are clinical trial.
Well, are you under popular?
No,
Yeah.
you got to go to properties.
Properties.
When I click properties, there's
Actually,
an
you have to be
options.
under
Yeah, it changed.
You have to be under popular?
for
Yeah.
this to come.
Oh no, my website's wrong. Okay, go to popular.
Okay.
And then
No,
click
not
on
popular.
clinical
Not-
trial.
Mhm.
Review. You should see randomized controlled trials.
Oh, I'm sorry, backtrack. So, click popular, not properties.
Yeah,
then-
click popular. If you scroll down, do you see randomized controlled trials?
Just see clinical trial.
Review is my last one.
Clinical
Mine
trial
too.
and review.
Clinical trials.
Mine too.
And
Items with abstracts.
reviews published in the last 5 years.
Are you sure? What happens if you go to properties?
It goes to.
It gives a lot of like.
It just gives age groups, clinical
You
queries.
should scroll down to the item that says types under properties.
Okay.
Oh, I forgot to tell you. So I guess it's below. Here, look. I did put it there.
Publication
Do you
types.
see this? Publication types?
Okay.
Yeah.
So you click on
Yeah.
publication types.
Oh, okay.
Do we
Okay.
clear the other ones we did?
Yeah, forget rid of that one. Just go to properties, scroll down to publication types.
Okay.
Okay. And then
Where is that?
Under properties.
Yeah. Oh, you can scroll.
Okay, then you see the randomized trials.
all right, so I want for you want a randomized controlled trial. You want all just clinical trials because that means you'll get open label
Yeah, you
trials
can
also.
everything is, yeah.
You want meta-analyses, and you want historical articles.
Oh, sorry. If you go to publication types, what are we supposed to do?
So the 4 that I think are you have to have as a minimum, and then you can do whatever else you want, are randomized controlled trials,
Okay.
clinical trials, because that will get you the open labels, meta-analyses, and reviews. You have to have reviews, so you can find reviews on anything you want. And then historical, I think you should have the historical one tab too. But you don't need that one if you don't like history. Just do the 4 are a minimum. Meta-analyses,
How does it work?
controlled trials, randomized controlled trials, and
If you hit clinical trial, does it cover all the phase 1 through 4?
yeah, but you want
Just
the RCT so you can say like, oh, there actually aren't randomized controlled trials on that drug yet. It has emerging, like it has potential, but we don't know.
So is it important for me to have clinical trial and clinical trial phase 1 through 4?
Versus just clinical trial.
I mean, do you want to be like a basic scientist?
No.
Okay, so just do clinical trials
Okay.
and randomized controlled trials.
Okay.
Okay. All right. Does everyone have their 4 filters?
And then review and meta-analysis.
Review and meta-analysis.
Okay, and that's all.
Those 4 are all you need. Okay.
1, 2, 3, 4, 5.
So just let me know when you're ready to move on to the next thing. You ready?
So it's
Okay. So now we're going to go to make our curated search. So this is what will make you superstars.
Do we have to like name this custom filter? Or is
Not
it-
yet. You're going to have to name your curated search. And you,
I'm sorry, what did we do next?
so the
We don't
next thing
have
we're going to
those.
do, does everyone have their filters?
Yeah.
Okay. So then the next thing we're going to do is go click on the NCBI tab again. Did everyone find in the upper left-hand corner or upper right-hand corner, you have an NCBI tab? So, My NCBI?
Oh.
Yep. Click on that. And then is everyone at this page?
Mhm.
So click on create some saved searches.
Where's
You should see in the upper right corner
Yeah.
a hyperlink. Okay, sweet. So create some saved searches. You got that? Okay, and then this should bring you to the next page where you can click on advanced.
We click on advanced now?
Yeah, click on advanced now.
Oh, under the search.
Yep.
Search.
So you're gonna go first. You pick create some saved searches. Your first hyperlink, and that takes you to the next page. And under the search bar in PubMed, click on advanced. Okay. All right. Now, do you see this page?
Yes.
Variation, yeah.
Yep. Okay. So let's just put in a couple of journals, just so you can do the rest later. I just want you to get the point. Like I want you to know how to do it. Okay. So someone tell me what the best journals are in psychiatry. Just like some good ones. Like that you'd be, if I quoted it, you'd be like, man, that dude knows what he's talking about. Journal of Clinical Psychiatry. Great journal. Why is that journal great? Because they actually care about clinical trials. So they publish clinical trials which have meaning rather than just like publishing like a rat has neuroplasticity. You know, like it's real. It's real. It has treatment application. So let's go to all fields. So you're gonna set this to all. The first one should be set to all fields. Is everyone on the first bar set to all fields?
Yep.
Okay. Now this next button to the left has to be on and. Okay. Now pick the journal. Okay. And now instead of I put in the American Journal of Psychiatry, you're gonna put in type Journal of Clinical Psychiatry or the Journal of Clinical Psychiatry, and it should auto-populate for you. Is it auto-populating?
Yep.
Okay. Now here's like the only thing that's important about like the technical process here is you have to use the word or next. Okay? Okay, so why are we using the word or to add our next journal?
Search multiple, this, or this.
Yes, so we're telling the computer we want to search all fields, so everything that's in the world that PubMed knows about. We want that as our starting point, okay? And then the next point is, in addition to like looking at everything in the world, we want to curate. So in addition to looking at everything at the world, it has to have and has to go with the following journals. But once we get to the journals, you can't keep using and. You have to start using or, because if you use and, you're gonna crush your search, right? Because we're saying we want it to be linked with this journal, with a number of journals, and it could be this one, or this one, or this one, or this one. But everything else that's not included in your or is going to get excluded from your search, right? So that's pretty cool. Why is that cool?
Because you have so much to see them.
Yeah, I mean, if you have 3 minutes in between patients, do you really want to do you want to look through every journal in the world? Or do you want to just look through the top 20 journals? You want to look through the top 20 journals. I'm not saying that there aren't great articles in some other random journal, but if you're crushed for time, you want to curate your search, okay? So let's just put in a couple of other things so we have like a start, and then we're going to be done with this lecture pretty much. Okay, so we put in one psychiatry journal. What other types of journals do we need to have in there? And I'm a little bit chagrined because I don't know much about medicine. However, I will answer my own question and say that we have to have medical journals in there, right? Because there's so much overlap between psychiatry and medicine. What's an example of overlap between psychiatry and medicine? Someone give me an example.
I guess in geriatrics, there's a lot of
I want a specific example, like related to a patient or
delirium versus
perfect. Delirium versus dementia, but what might get published in JAMA, or the New England Journal of Medicine, that you might care about?
It's like cardiac health and depression.
Beautiful. So like, what do we tell our patients who are on clozapine and if they're obese? What do we say? We say lose weight, but do we think about using a statin? Does your primary care doctor have you on metformin? Right? You have to know those things, because what if the person's primary care doctor isn't very good and you're treating that person with a drug that has metabolic side effects and is killing them? So you have to have a minimum of the JAMA and the New England Journal, and I would say let's represent for the Lancet, because that journal is super cool. Yeah. All right.
Can you put two journals in
No.
that one slot?
Nope. It's always got to be an or.
Oh,
JAMA.
so
So you do. So you're just gonna follow it up. Everything.
so the first one is an and then everything else.
Everything else is an or, but although it's gonna end with an and, because that limits your search. Right? It's gonna be a blank and at the end. Okay.
Psychiatry.
So put in JAMA and the New England Journal of Medicine and
Oh, shoot.
and the Lancet.
For Lancet, there's a few different options.
One in England?
Who cares? Just put in one of them.
Okay.
I'm sure it's the Lancet. Like how many? I mean, they're probably just giving you like different time ranges or something. So pick the one that has a dash that doesn't have an end after the dash. Is everyone done with their medical journals? Almost done?
Good job.
So then, what other category? And then we're done. We can bail. What's the last category? In addition to psychiatric journals, which all I want you to do after this lecture is go Google psychiatric journals with the highest impact factor. I also have a link to it on my website, and it'll give you like 30 journals that are good. And put in as many as you want. I would say, though, that you need at least 20, right? Because there are going to be things that are so tiny but mean so much that you need a lot of journals. For example, we had a patient with NMDA receptor encephalitis, and there's not that much on it. Or, Brittany, we had a patient with brief psychotic disorder, and the literature is crap, right? There's like nothing out there. So when we tried our curated search, or at least when I tried the curated search, I got nothing. Like I didn't get that much that was that useful. And I had to go and just put it into all of PubMed, and I still barely got useful articles, right? So, and why is that good? If you get nothing from the journal, from the literature, like a minimum of information, why is that good?
You can design your study. You can,
But why is that good for you and your patient?
they can be a case study.
No, because you can embrace uncertainty with your patient. So Tom's my patient, and you've got brief psychotic disorder. Don't worry, it's residency induced. You're okay.
They had
So I'm in the room with you now, and I'm saying this is the assessment section, and I'm typing. I just sent you an article on, or a link to how to do concurrent documentation, or an example of it. So I'm typing, and I'm saying, maybe I don't type for this because this is a big deal. I say, we've spent an hour, and I've been trying to think this through, and my working diagnosis is that you have a condition which is called brief psychotic disorder. And say I don't really know what's up with brief psychotic disorder in the session. What would I say to Tom?
I don't know.
Exactly. I'd say, it's not that common, and I haven't reviewed the literature recently, so before we proceed with treatment, I'm going to need to take some time and do a quick review, and I can try to get back to you tomorrow. I mean, this is not an inpatient unit, right? This is outpatient. The person doesn't need to be in the hospital. It's urgent, but it's not acute. So you get back to Tom when you can, as urgently as you can, right? But if you do know the literature, then you can embrace uncertainty with Tom, and I can say, there's not that much clarity in the literature. Like, we don't totally understand it, but it does appear that a subgroup of people will get completely better, even off of medications, and a subgroup of people won't, and we don't have a way to predict it, so it's really hard. So we're going to have to work through this process and kind of test it out ourselves, but there's no way to know now, like what the course of this condition is, right? So do you see how that, like, it both liberates you, and it's a form, it's the right treatment, because we don't know. Am I just saying the same thing over and over again? Okay, kind of. Marie's like, and Maura's like, yeah, a little bit. You said that 10 times. Okay, all right. So, what's the last field that we need to put in before we can all leave? That's a good idea, although I think psychology has its own literature base, and if you are, I'm not a therapist, but if you're doing therapy, then maybe it would be a good thing to like figure out what the journals are and put that in. But I would say the last field is to put in a couple canonical basic science article journals, right? So Nature and Science need to be added in there. And before you do it, the question is why? Why do we put Nature and Science in there? Who cares what they're doing in the labs with rats?
Like new upcoming treatment options?
Yeah. So like for example, I mean everyone might know this now, but when I was doing research, what we were looking at in my lab, or what I was focusing on at the end of my research career, was the relationship between inflammation and depression, right? So it's much more out there in the world now that there is a relationship between mood and inflammatory cytokines. But back then, like, if I typed in the Journal of Clinical Psychiatry, would I have any idea that there could be a relationship? And when your patient who comes in with depression after taking interferon says, I'm depressed for the first time in my life, it's really weird, I'm 55 years old, I don't have any psychiatric history or genetic loading for it, but I'm depressed, how are you going to know that there's a relationship between inflammation and depression, right? That's how you're going to know, because you're going to type it in, interferon and depression. And it's gonna pull up in Science and the Lancet before it pulls up in the Journal of Clinical Psychiatry.
How do you find Science in here?
I think it's the same problem as the Lancet. Like, does it pop up? Does it show you like 20 choices?
Yeah, does it make sense?
Oh, that's 2 different categories?
Yeah.
No, you
There's-
just type it in the same.
Just type in Science. It should pop.
Oh,
Oh, I did it in the same thing, like Nature.
So it's the
Science.
Nature.
Oh no, that's
That's a different
that's one
one.
journal. So you want
Yeah.
Nature is
And
one
then
journal,
Science.
All your stuff is
Okay.
more.
and Science is another journal.
I just,
Oh, it does. I'll look at it with you. And so
Oh,
That's still.
Yeah, it's easy. I did the same thing which you did, Tom. But that's okay. I did it like 5 times, but it's easy.
Wait, you went forward? And they have to type everything back in?
Yeah. That's fine. We'll be able to do it.
yeah, it could be PC versus Apple. So wherever you're at, we're running out of time, so let's just save our search, because you now know how to do it, and there's an article on the internet on my website which tells you how to do it if you forget,
Okay.
right? So let's save our thing. So is everyone's last line and then blank?
I got words on blank.
I did something though.
I did the same thing.
We only put 6 different journals.
That's fun.
Is that
Yeah, it's a good
right?
beginning, right? Because you can update it at any time.
So
Okay.
the science, science was my last one.
So
Should
on the
that be an and right next to it or an or?
no, that's an or, but then
That's
below
an or.
your last journal, you should see an and.
And then blank.
That's like the period at the end of your sentence, right? So this is an and then that's blank.
Oh.
Does everyone
Okay.
have that screen?
Mm-hmm.
Yes.
Yeah,
Okay,
yeah.
so now you're going to click on Add to History. What happens?
Something.
It's loading. I don't know yet.
Oh my
Quoted
God.
phrase
This
not
came
found.
out. Yeah.
What came out?
Quoted phrase not found.
Okay,
I messed up
Something went wrong.
somewhere. That's okay.
somewhere.
I'll do it with you after.
This just.
Yeah, that's.
you forgot to add to history.
Items found.
Oh no, adds in history.
That's okay. So 27,000 is the total number of items found if you don't put a search term in. So when you put your own search term into that PubMed, when you're signed into your own account, you're going to be able to search for things among 27,000 articles. That's why you want to have a pool of like 1 million articles to search from, right? 27,000 is not enough articles. Okay, so we should be at, are most people at this number?
Yes.
Do you see a number that says number 1
Yeah.
or number
Yeah.
2? Okay,
Number 4.
number 4. So click on your top number.
Number
Whatever the top number is for you, click on it. Okay. And then
Oh, this didn't come up.
does maybe I went too far. So what happens next?
This
It's like
comes
a
up.
drop down list.
Yeah.
Now click on
When you click on the number, you get a drop down.
And history.
So
And
after you click on your search number, you should then choose Save in My NCBI. Do you see Save in My NCBI?
Yeah.
Okay, save it, and then call it whatever you want.
If I got that error, should I be saving mine?
Now we'll work on yours later. Oh yeah, no, do it. Let's see what happens.
So
Yeah.
save it, the part where the name of the save search, delete, because mine somehow has everything that I put in, everything that we put in there. Like all the journals that we put in there is what,
Like
it's
the
given
name.
as a name.
and then you
So just
name
delete
it.
it and
You
you
could-
name it the way I want.
Yeah, name it whatever you want. Like you should see in the search, you can erase it and then just I call mine favorite journals. The reason I call it favorite journals is because you're also going to create a list of your favorite authors. Like as you start to read the literature, you'll be like, dude, that review was awesome. Who was the first author? And then you're going to add that person to your favorite authors list. Because anytime you want to read about, I don't know, antidepressant side effects, you're going to say like, oh, that guy is the expert. Okay, I think we're on the last thing. We're almost done. So sorry. Okay, are we? Okay, so now you clicked on your favorite journals. You've named it, and now let's test it out. Okay, so go to your basic PubMed page.
Should we save it first or no?
Yeah, save it.
Save it.
Okay. All right. So does your PubMed page look like this? Like the top has a ton of. Okay. So yours we're gonna fix. Okay, but this search details, right? Do you see like a box which has a bunch of search details on it?
Mhm.
Who's at that page?
Mine's like loading slow.
1, 2,
Or you want it?
3. You got it?
Yeah.
She does.
Okay, so you can all do this later. It's all on the internet, like how to do it. So you probably just made a mistake along the way and you can fix it. Okay, so now what are you going to do? You're going to go to your search details box and go to the very bottom of it. Okay, and are you at a place where you can type? Is your cursor at a place where you can type? All right, what do we want to research? What's our question? How about treatment for bipolar 2? Because that's like actually kind of hard. All right, so how do we do that? Type and. Type the word and in capitals. And you're going to type bipolar 2.
All capital?
And then do we put or and after the bipolar 2? We put or and after.
Because if you don't want to do
And because we want them both in there, right? If we don't want to exclude treatment, we want to include treatment. We want to know about the treatment for bipolar 2. We don't just want to know about bipolar 2 as a separate thing or treatment as a separate thing. We want to know about treatment for bipolar 2, right? What if we wanted to make it even more specific? What could we do? Would we add an or an and? And what would we add? How about antidepressants? Or actually, let's do SSRIs. Because are they the right thing to use or not? So put an and put SSRIs. All right. Or actually, you know what would be nicer? Let's get a little bit, let's not confuse PubMed. Let's just call it serotonergic antidepressant. Or just, if you don't want to do it, don't do it. And let's just test out our algorithm.
Right.
Okay.
Search.
Click search.
Yep.
Did it work?
200%.
Yeah.
Okay, so now let's pretend that we're just like hardcore empiricists. The only thing we believe are data from randomized controlled trials. Go to your filters. Click on your filter for randomized controlled trials.
Oh.
Click it.
Okay.
How many randomized controlled
Zero.
There are only 3 articles?
I have 46.
I have 0.
2.
I have 15.
Okay, so why is that? Because we over-curated. You don't have enough journals in yet. So if you populated once you populate your own curation algorithm, you'll have 20 or 30 journals in there, and you'll probably get 20 studies, right? But let's see the difference between randomized controlled trials, which cost $1 billion to produce, and open label trials. So click on all trials. Now just go to clinical trials. No, just clinical trials. Go to your filter for clinical trials. How many do we have? 26.
What did I do that I have 36?
You have 36?
I have
Awesome.
25.
Okay,
I
cool.
have 275 articles, but 0 of anything.
Okay, so but somebody, at least a couple of you have it. You can fix it later. Okay, so now we're just illustrating the process. So now let's look at meta-analyses. How many meta-analyses have there been, at least in our limited pool? You have 3? 2?
0.
0? Okay, but that's great, right? So you said, I want to look for a meta-analysis, which, would you recommend that someone do that? In an area that's not that well studied? Probably not. Good idea. But you can still do it. But you want to look for a meta-analysis, and you only wanted to look in the top journals, and you did it. All right? So we covered meta-analyses, clinical trials. Oh, reviews. Go look for a review, because
4.
that's going to be, so that's your money, right? So if you find, we're going to go back to the omega-3 question. So the resident and I are sitting in the room. We don't know what dose of omega-3s to give to our patient. We put it into our curated search. So the first thing I'm going to look at is reviews. And if I found a good review article from 2017 on omega-3s and unipolar depression, I am money, right? Because it's going to summarize the data for me. And it's recent enough that it's reasonable. It meets standard of care as a doctor to say, I've reviewed the literature, and we're going to titrate up to a dose of 2,000 milligrams with an EPA to DHA ratio of 3 to 1, right? We can do that. So you're going to use reviews all the time. All right, I think we're done.